Good morning. Thank you for inviting me here. Thanks, Mira and other organizers that allows me to talk about something that most of our younger colleagues, they forget where it's come from and where it's going to go. And I have no disclosure. I mean, we have to, in the United States, we have to mention that. I will talk about, I'm a radiation oncologist. I will not talk about chemotherapy, immunotherapy, target therapy, any kind of different kind of mother therapy. Now, I'm going to concentrate on a couple of areas. However, even though it appears that some of us, we were around during this era, but most of us were not. This is might be for my age and before age of even some of our senior colleagues. But they are all, truly they are milestones that each of them needs an hour talking, but I will not talk about them. Now, I'll talk about latter years, the ones that at least I was personally involved. And I'm going to, at least in my personal view, what is from all these, which one is a true quantum leap that changed the practice of radiation therapy, and in that matter, practice of care of cancer, at least in my opinion. And I hope you agree. Now, quantum leaps has different meaning for different group of practitioners and investigators. Could be organizational, could be clinical. Physics, they think they have quantum leaps. Biology claims it. And we got technical. But I'm going to be talking about fundamental issues. Now, let's say organizational. If you read some of the books, they think that the development of here, astro, estro, gestro, and all those, all kind of throws, they were, these organizations, they were quantum leap. Bunch of radiotherapists get together, now they have an organization. And hopefully we'll have Tanzania radiation therapy oncology in future. This is a brief history of astro, which I know most of it. These are all various steps of starting when this was the American Club of Therapeutic Radiologists, developed by a bunch of radiation radiologists. At that age, they used to call them Young Turks. And then gradually, they officially incorporated, they got, and so people, they were involved, they would think that each of these steps are a quantum leap. I would say no. They are just progress of various functions. Clinical. A lot of areas that we can think that any of these could be considered quantum leap. Clinical trials, it could be. Defining therapeutic ratio, recognizing cure versus complication, could be. Interjection of statistics, could not be, but something they are. But they are all, again, progress of along the way of the way we practice from year to year, from decade to decade. Could be physics. Physics has done significant contribution over these years, and they have characterized the physical properties, and they have done huge amount of work a long way with us. But again, in my opinion, these are all progress along the way. As we go along, we develop new things to use it better, to improve our clinical care of our patients, whether they are basic research or applied research or clinical trials, but they're all part of the progress. Biology is another one. Again, a lot of biologists will think that they have had quantum leaps in the management, in the progress of this clinical science. Natural history of different tumors based on cell types. Dr. Ackerman believed that was the quantum leap. Staging of cancer. Now we stage cancer. We wouldn't do it some years back. Dose response fractionation. Biologists think that is a quantum leap. But again, at least in my opinion, you may disagree or not, these are all progress along the way that we have made. And this is another picture has been shown in almost every textbook. We're having growth disease versus high concentration chronogenic microscopic disease, subclinical disease, and low-cost disease. But again, these are all part of the... Now, I'll be talking about, in my opinion, the fundamental quantum leap is... And by the way, brachytherapy has its own pathway, which is separate from what I'm going to talk. So this is also my personal exclusion. I'll be talking about teletherapy. And what is why I'm talking about teletherapy and which portion and when we call it, this is a quantum leap progress, a major. And the reason I use that, the one I'm going to talk about involves organizational, physics, biology, and clinical. That is a true quantum leap. What is it? Is this teletherapy? Teletherapy going from that one I haven't seen, but from here on, I have personally treated patients all the way from this end to the here. To my opinion, going from all these to mega voltage radiation therapy was quantum leap, to my opinion. and that, to my opinion, again, called cobalt-60 era. Although some people think that this is also was part of the same era, I have actually worked with this machine in Shattuck Hospital in Boston, but believe me, is not something you want to even treat your enemy with it. It is unreal. But the cobalt-60, cobalt-60 was called cobalt era, is the quantum leap era in the radiation therapy. Little instant, 1971-72. As a resident, we used to work on 1 month on each therapy machines as a technician. So I personally worked on these cobalt machines as a therapist, 3 months. And incidentally, we had something called Cobalt 1 those days in Boston. That was 1972-73. And then about 2006, when I visited a friend in Rosario, he showed me a cobalt machine. He said, you know what's this? I said, the cobalt machine, you know, made in Canada. This is the same cobalt one that he used to work on it. 36 years later, still treating patients. The longevity and reliability is the one that makes cobalt machines more favored. Important features of these cobalt teletherapy is relatively high energy gamma ray emission, relatively long half-life. You don't have to replace them every other day with all the troubles and costs. Relatively high specific activity, relatively simple means of production and working. That to me makes it ideal machine for many areas, including institutions outside of the United States and Europe. Now let's look at this. This is taken from one of the publications by physicists. Build up cobalt 6 MeV, 15 MeV. Yes, we know build up is a little bit different between these three. But if you know how to use your machine as your physicist, you can overcome this in no problem, in a split second. Skin dose, the percentage of the dose you see in skin or the build-up area, the same thing. Again, if you know how to use it. We treated hundreds of patients with that machine, and this was never any problem. Penumbra actually can, with the current work, can be our advantage. And the other one is the penetration depth. It's about 10 cm, as well, half of it, a little bit more with these. And again, you can use different techniques of multiple beams you can overcome. Rest of them are almost the same. So there are few things are different between the cobalt and other Linacs, but they are not overwhelming or impossibility to take care of them. And the rest of them are different. The rest of them are basically the same. So the question is, has the time come for us doing away with cobalt as a cancer treatment? This question has come up more and more and more, and I know I'm going to get shot by variant people sitting in the back, but I have, I'm going to be behind the shield. The answer is yes. If you find a sugar daddy, gives $6 million to this gentleman to get one of those modern neo-Linacs. No, if you know, you use cobalt machine, and you can do whatever you want with modification of the cobalts. Despite clear technological and practical advantages of Linacs over cobalt-60 machines, the latter still occupies the important place in the radiotherapy of armamentarium, mainly because it's constantly low cost installation for installation maintenance and compared to Linacs. In developing world, cobalt-60 is because of relatively low cost, simplicity of design, and ease of operation are likely to play and continue to play important role in the cancer therapy. Many modern features, this is the important piece, of Linacs, such as MLCs, dynamic wedges, and dynamic operation, could be installed in modern cobalt machines to allow, at lower cost, a similar sophistication in treatment as Linacs could be produced. We have to know that. So you can do that, and it's being done. Now, I'm going to change. The other one is the quantum leap, in my opinion, is this. Going from all 2D to 3D volume. This is my professional life, about 20-some years I've spent on this specific issue. We have gone, my qualification is that I have worked from 1D to 2D, 3D to 4D. I have worked with 3D CRT. I wrote about it, all of these, IMRT, IGRT, etc. SDI, all of the other modern gadgets or modern gadgetial techniques. Now, this is with one slice of CT scan. This is one dimension. Can you imagine using this one slice CT scan? We have done that. Some of us, we are older, we have done that. Use one CT slice of chest X-ray to treat a lung cancer or a breast cancer. We have done that. But can you imagine a human being being like this, or adding one slice of CT scan to make it 2-dimension? I don't believe there is absolute proof that human body is 3-dimensional. It is not 2-dimensional. Now, we have to acknowledge that we treat human volumes of tumors with volumes of normal tissues. Therefore, we have to contend with the volumes of whatever we do. Now, because of that, recognizing that in probably mid-80s, early 80s, the impact of, because of the computer's progress higher and imaging technology got higher, software technology, modeling got in progress, all of these resulted in a significant progress, allowing us to go from 2D to 3D, which was part of a huge, almost 10 years of NIH contract that I was involved. We went from this era, and some of us may remember, we were drawing patients on the patient face in the exam room and taking an X-ray. Drawing the, we don't know what's inside this. Cancer could be anywhere, but I think it could be here. And we don't care it's bone there or air there or tissue there. But just calculate at the midline and shoot through the physics tables. From this era, we have gone to this era, that we can three-dimensionally look at all the organs inside the body and concentrate on their progress during 3 courses of treatment, the amount of dose, amount of calculation, etc., complication, etc., etc. There's another. We can see the tumor, we can see the node, we can see brachial plexus, we can see parotids, we can see, and areas we want to treat to what dose and etc. So we have come from that era to this era, although has been a higher cost. And by the way, you can do, this is from Linac, but there are ways of getting around it. You can do it with modern cobalts. But there are machines, they can do this. This is one of those machines, not for propaganda, but this is one of the machines I use for it. So along the way, we have come to recognize various tools. We have photons, electrons, high LTEs, multi-level collimator, intensity modulator, image-guided, adaptive gated. All of these are progress along the way since development of 3D CRT. These are not quantum leaps. These are just progress along the way. Going from 1D to from the one single shot to the volume, recognizing that human body is volume. That was quantum leap. These are all progress, good progress, but nevertheless does not reach, in my opinion, to the level of quantum leap. We have had now a whole bunch of new gadgets. We have new machines. God knows the price of those. Novalis, CyberKnife, Gamma Knife, and each of them they are fighting for which one is better through advertisement and TV and etc., etc., etc. And you see signs of these signs of this wall in the highways of the United States, tomotherapy and all that. So all of these, to me, again, combination of progress and combination of marketing, having new gadgets, putting a new name on it. They are not quantum leap. And Dr. Mont will not shoot me here. I'm sitting. To me, discovery of potato to be as a food was quantum leap. But then knowing that the potato has a volume, you can play with it, is quantum leap. But then we got progress. We got potato chips and IGRT, IMRT, whatever, all kinds of, and there are books are written about any of these. So to my opinion, they are the two bottom to the quantum leaps are, one, the ability to treat patients, the tumors at the depth of the body, where they belong. Not all the tumors sitting outside the skin. And then also going to the volume of it and ability to get to that through megavoltage. And the bottom line is the maximum tumor control with minimum side effects, safety of patients, safety of personnel, and safety of our environment. Thank you.